Hello. Today I would like to dive into a topic I like to call the continuity of care, or lack thereof, in which communication and Taylorism collide, specifically focusing on an organizational situation within the hospitals of Pittsburgh, Pennsylvania. I'd like to start off with a brief review of Taylorism to help jog everyone's memory and set the tone for my organizational tie-ins. Frederick Taylor was a Pennsylvania native who became famous for his time spent first at the Midvale Steel Company. It was in Midvale where Taylor worked his way up through the rankings into his first position of management. There he coined the term soldering, which we all know that he found that workers were working slow on purpose. So this really bothered Taylor, and he wished to truly maximize output as much as possible. Yet he still wanted to maintain fairness for the workers that he once worked side by side for. So, and thus, the birth of Taylorism became possible. He went on there to run his infamous stop clock studies to determine how each job could be ran most efficiently. Now, we fast forward here to Taylorism in 2018, specifically focusing in Pittsburgh, Pennsylvania, where we can expand it to the ever so fragmented medical field. Hartsband published a highly criticized article in 2016 relating the Taylorism that takes place in the Toyota car factories to that of what should happen to the medical field. Hartsband discusses the issues of the patient emergency room wait times, as well as the most optimal time allotted for doctor and patient interaction. She goes on to make a legitimate case that the medical field should be just as streamlined as that of the car production factories. It was with these ideas that she coined the term medical Taylorism. In response to this article, Houston wrote on the possibilities of Taylorism going too far in the medical field, opening up the floor for debate around a new sense of unwanted urgency in the medical field, and thus all adding up to more simple mistakes. So a little bit of background. Here's a little bit of information on the story in which my organizational situation spin off of. My late grandfather was sent to Pittsburgh, PA by his primary care physician in order to undergo chemotherapy in an attempt to combat a chronic form of leukemia. While undergoing a course of treatment, my grandfather developed an infection in his arm that placed him in a critical condition. He was then transferred and admitted to the ICU of a larger community hospital still in Pittsburgh. This hospital is one of the many nation-renowned facilities for quality of care in the United States while in Pittsburgh. My grandfather's case grew in complexity as more and more medical eyes analyzed this case in order to help discover the infection. The outstanding issue was that the platelet count was consistently too low to risk an exploratory surgery. So as many medical professionals went in and out of my grandfather's room, things began to feel like a whirlwind for all family involved. This whirlwind continued for my family all the way up until my grandfather's final moments within that same hospital's hospice wing. So the organizational situation, number one. So this hospital utilizes a procedure that calls for doctors to rotate floors and units every so often. My family was told that this was to ensure doctors stay well-rounded and that multiple eyes can be exposed to a case during an elongated stay like my grandfather's. Now, this sounded like a splendid idea to my family after they understood that more eyes would likely lead to a faster resolution of symptoms for my grandfather. The issues began to arise when the new doctors would come to discuss things with my family, yet they would contradict or say something completely different in a different direction than the previous doctor that was working. The theoretical explanation. Frederick Taylor would view this concept being employed as the most efficient route to help solve a complex case. The idea is streamlined in that it could help something be treated faster because it is essentially a team treatment by the doctors. This approach is not as quantitatively measurable as Taylor's clock studies were, but a likely efficient resolution to an abstract issue altogether. This would in turn help save healthcare dollars and, in the grand scheme, help solve a more national issue. The theoretical application. So, the solution involves applying just enough Taylorism to the policy without losing the ethical side of proper patient care. The doctors simply need to set aside focused time so that they can brainstorm how each critical patient's plan of care should be tailored. Families should not be put in a contradictory position when they are grieving for a loved one at a bedside in an ICU. Emotions are very high, and conflicting scenarios, regardless of the magnitude, they make for confusing and distress that's unneeded on the family. I believe the doctors in Pittsburgh could implement an idea similar to that of the Massachusetts General Hospital. In Massachusetts, they use something called bedside rounds. This is a new style of rounds that would leave no doubt for the patient and family on the direction of care because they would be directly involved. Typically, rounds take place on a specific wing of the hospital in which everyone that is directly involved in care is supposed to gather in a room and all come to meet, but that does not include the patient or the family members. This style of bedside rounds would actually streamline all forms of communication because nobody would need to communicate other than during this round. All staff that is pertinent would be informed, and the family would never have to endure misinformation like my grandfather did. The struggle is, how practical is this really to introduce bedside rounds? So, a gentleman by the name of Gonzalo analyzed the benefits and barriers to implementing bedside interprofessional rounds in a hospital. Research was conducted on a 378-bed hospital in central Pennsylvania. This hospital has lights outside the patient rooms that, when on, indicate a bedside round is taking place, so that the appropriate staff can be signaled to attend. The primary barriers relate to time and staff schedule, and specifically isolation precautions that some patients carry. The highest rated benefit reported was improved interprofessional communication and coordination. It is clear that the bedside interprofessional rounds represent a great opportunity for improved continuity, and overall, definitely would have helped my family and my grandfather out. Organizational situation number 2. One glaring issue this hospital made very obvious was the lack of continuity between the day shift and night shift doctors. Each night, a new physician would be in to cover the active daytime physician's patient. The incoming night shift doctor would consistently be unfamiliar with my grandfather's case when he walked into the room. It was blatantly obvious and became very frustrating for my family, as it felt like every minute was of importance in further determining what the source of my grandfather's infection was. It seemed like each night the doctor would fumble over his words and have to go to the nursing station to dig up more information on my grandfather's case. Theoretical explanation number 2. Frederick Taylor could look at this situation as he did during his clock study. He would see that the night shift doctors had been wasting productive time by having to go specifically find information to better familiarize themselves with my grandfather's case. Just as he saw his workers taking unnecessary steps in the factories, Taylor would find a way to streamline. This would be a very calculated move that would help cut costs and improve quality of care for everyone involved. Theoretical application number 2. The hospital is in desperate need of Taylorism in order to save its overall quality of care. The hospital needs to reconsider its policies on communication during shift changes. They could look to adopt a new method similar to the IPASS method that White proposes. In the IPASS method, it is used as a mnemonic, the term IPASS, to ensure communication is consistent and appropriate. I representing illness severity, P representing patient summary, A, action list, S, situation awareness and contingency planning, and the final S, synthesis. 9 hospitals participated in this method and saw a 30% decrease in communication issues. A method like this could be beneficial for all hospitals to follow up to keep communication consistent every time. In studies of the ICU's poor collaborative communication, it was found that they contributed to as much as a 1.8 times percent increase in hospital length of stay and mortality rate, according to Dingley et al. Organizational situation number 3. While in hospice care, the doctors are staffed so that each doctor covers his or her absolute maximum number of patients possible. This was made quite obvious when a new doctor came in to see my grandfather and give report to my family. This doctor looked my grandmother in the eyes and told her that my grandfather will not be able to recover from the brain damage he experienced when his heart stopped the previous time. This information was completely stunning for my family and absolutely incorrect. My family was sent into an uproar because my grandfather had experienced 0 brain damage and had no trouble talking with them at all. And to make matters worse, this doctor had never come to see my grandfather at all. Theoretical explanation number 3. So this new doctor clearly had made a huge communication error. It is vitally important in healthcare to be positive that all facts are correct before delivering news to patients. Frederick Taylor would step up to the plate and see exactly where and why the new doctor went wrong. And if his wrongdoing was significant enough to make a causation for change. This doctor apologized later, stating that he was under the impression that my grandfather was no longer to speak or react because somewhere in the charts he read that the patient does not respond to commands and his heart stopped recently for a short duration. Theoretical application number 3. My family was very angry, and rightfully so, that this doctor had made these assumptions about my grandfather without ever coming in to actually see him in person. My outstanding solution to this simple situation is communication. Use Taylorism like the iPass system we talked about to keep medical teams more in sync with one another. This scenario did not result in any major malpractice incident, but an error in similar nature in a different scenario easily could have. The CRICO Strategies is a division of the Risk Management Foundation of the Harvard Medical Institution Incorporation. They conducted a study analyzing national malpractice claims, finding that 30% of all claims involve an error in miscommunication. A further analysis of the CRICO Strategies reports by Kern found that 44% of that 30% of miscommunication cases reported were in inpatient settings, similar to the ICU. And also that 57% of the cases reflected provider-to-provider miscommunication. A provider-to-provider communication error, like the one my grandfather had in hospice, is much more likely to result in a payout and should at all costs be mitigated. So, in conclusion, Taylorism and the medical field are two things that the world really wants to see mesh together smoothly. I believe that we just need to find the right strategies that would make the medical Taylorism theme work properly. One of the largest contributors to patient injury and death is miscommunication during shift changes. My grandfather was a prime case example of miscommunication secondary to the lack of properly inserted ideas of Taylorism. In Lieber's book, he mentions additional strategies to adopt in hospitals to help prevent malpractice, secondary to communication issues. Lieber's number 1 suggestion is to adopt a structure for handoff conversations between providers. At no point in time should any patient or patient family member have to endure any additional trauma, physical or psychological, secondary to a simple lack of communication. Thank you for listening to my presentation. Here are my references, and I hope you see the way that I applied Taylorism to my grandfather's personal situation.